She completed her categorical intern medicine at Mount Sinai after enrolling in the healthcare leadership track, during which she focused on healthcare delivery science and quality improvement initiatives with local implementation. Her areas of interest include improving ED-ICU interface, improving critical care delivery and outcomes of patients with critical illness, regardless of the location of their care. She has served as part of the Mount Sinai site research team for the NIH, NHBLI-funded PEDAL Clinical Trials Network, the SCCM Discovery Network, and several COVID clinical trials, including ACTIV-3B and STRIVE. She completed her master's in clinical research and the ISMMS Emergency Medicine T32 program in 2019, studying critical care delivery in the ED setting. Her research and clinical focus is on critical care delivery in non-critical care settings, for which she received her K23 award for implementation tools to promote the evidence-based care of patients on non-invasive respiratory support. She's also the recipient of the Distinguished Scholar Award from the School of Medicine and currently serves as the Associate Program Director for Critical Care Education for the PCCM Fellows. I know that whenever I hear talks from Neha, I always feel better about high flow and non-rebreather. So thank you again for coming and talking to us, and I will let you take over.
All right. Thanks, Evan, for the introduction. And thanks everyone for joining my talk. And really, it would be great if we can have it be a little interactive because I think this is something that we all face regularly as we take care of our patients on the floor, in the ED, in the ICU, or in step down. Like the choice between what type of respiratory support we want to use for patients who are acutely or critically ill. If it'll move. I usually like to start with a case because it kind of puts everything in context. And this is a case of someone I actually took care of on a few weeks ago. So let's start with this is a 46-year-old man with diabetes, hypertension, poorly controlled HIV, and mild intermittent asthma, who presents to the ED with dyspnea and fevers for 3 days. He appears ill. His respiratory rate is 35. He's working moderately hard to breathe, and his saturation is 82%. So he started on nasal cannula, which is quickly increased to non-rebreather. He's now saturating 90%. I know because a lot of you are thinking about it or are going to ask for it, this is the arterial blood gas that the patient had on arrival, and it shows a pH of 7.47, a PCO2 of 28, and a PaO2 of 88, and a lactate of 3. And this is what his chest x-ray looks like. So the first question I'd like to ask, and you guys can, I guess, type in the chat or chime in, is what would you do at this point? Would you start hyponasal oxygen? Would you start non-invasive positive pressure ventilation via an IV? Or would you intubate the patient for invasive mechanical ventilation? Or none of the above, just leave him alone on non-rebreather. He just needs a little time to get better. What do people think? Evan would intubate? All right. So I'll tell you what actually happened with the patient. So he was placed on high flow nasal oxygen at 40 liters per minute at 80% FiO2, and his SpO2 improved to 94%. So he was then triaged to step down unit. But as is also usual, he kind of remained in the ED for the next 18 hours. So my next question is, how often would you actually evaluate this patient? Would you see them every hour? Has the primary team watch him, assess him every 4 to 6 hours? Would you assess him when the SpO2 monitor alarms, or when the patient is decompensated and needs emergent intubation via RRT? What would typically, and I think almost 2 to 4 probably happen often, and 1 is probably never, but those are our usual options. So this patient was assessed at least 3 times in those 18 hours. The high flow was titrated as low as 40 liters per minute and 70% FiO2. He was transferred to a step down unit, but had essentially 2 RT calls over the next 48 hours. On the first call, the patient was given Lasix, but he stayed in the step down. On the second call, he was placed on an IV of 18/5 at 100%, and then he was triaged to the MICU. Over the next 48 hours in the MICU, the patient stays on an IV at 100%, saturating about 89 to 92%, with some transitions to high flow for eating and for routine oral care. And on day 3 of his ICU, his oxygenation worsens, but saturations remain about the same, with occasional desaturations to 84 to 86%. But patient appears comfortable. He doesn't want to get intubated. So we're kind of tolerating the 89 to 92% at this time. So what would you like to do at this point? If you can tolerate the NIV longer, he might get better. Would you increase the EPAP and add INO? Would you intubate now, or you continue to monitor and intubate when he decompensates? Again, these are choices that we often have and actually do. Like depending on the patient or the provider, we've done all of the above. So it's just kind of, again, goes back to a little bit of the common dilemma that we face. And sorry, Pranay asked, is he still tachypnic when he's on high flow? And yeah, he's mildly improved in tachypnea, but not much. He was still tachypnic. So this is what happened to him after 2 more days on an IV. He's tolerating an SpO2 of 88. It looks calm. But on day 6 of ICU, he becomes more tachypnic, SpO2 drops, and he gets a SpO2 as low as 71%. He's emergently intubated, placed on lung protective ventilation, INO, and is proned. He's at this point not an ECMO candidate given the duration of non-invasive use. So this is, again, like going back, sorry, someone want to say anything? So going back, there's obviously different choices that people make as the patient's clinical course progresses. And there's sometimes a right and wrong answer, but a lot of the times when we're assessing a patient at the bedside, there's no real right or wrong answer. For example, does our choice of respiratory support during the patient's clinical course matter? I ask this rather leading question, hoping that most of you will say yes, but understanding the implications of the timing and duration of the use of these support modalities, while also considering all the different factors that influence our use of them, is important in modifying or helping optimize respiratory failure management. And to kind of show what are all the different factors influencing our selection, I want to go back to some of the Mount Sinai data that we have. And most of my data is from ED use of non-invasive. So I'll preface it by saying that this is not what happens across the Mount Sinai health system. There's some data from the health system, but this is mostly from our MSH ED. So for this study, we looked at all patients with acute respiratory failure that were intubated and required ICU admission within 48 hours of arrival over 24 months. This was pre-COVID data. And we stratified these patients first by whether or not they were exposed to non-invasive respiratory support in the ED, and this is high flow and NIV. And within the non-invasive group itself, we stratified them by how long they were on NIV, by a short duration versus a prolonged duration. So the data is from 431 patients who presented to the ED that required ICU admission within 48 hours after intubation. This is over 24 months. And our primary outcome was persistent organ dysfunction or death at 28 days. This is an outcome that combines death at 28 days or requiring new renal replacement therapy, continues on vasopressors and requires invasive mechanical ventilation 28 days post-admission. So, we also looked at the individual outcomes as well. And in this data, we actually, after adjusting for severity of illness, the reason for respiratory failure, we found that there's almost a 4 times increase in odds of POD plus D, persistent organ dysfunction or death, in patients who had an extended duration of NIV use in the ED before requiring intubation. And this was primarily driven by mortality. It wasn't like vasopressors or ventilators or new dialysis, but this outcome of increased odds was primarily driven by mortality. We also found an increased odds of in-hospital mortality for these patients who had a prolonged exposure for NIV. So, I'm not sure why my screen isn't moving. Okay. So we might all be thinking, okay, no NIV is needed, that we don't want NIV. NIV seems to be leading to bad outcomes. But it's not really as simple as that. That was pre-COVID data. Now I'll transition briefly into some more data from the COVID-19 era. So this is data from from one of the observational studies that we conducted through the PEDAL network called Red Coral. It was essentially all patients who presented with symptomatic COVID-19 infection that was admitted to one of the 57 PEDAL network hospitals from March to April of 2020. So this is just 1 month over the course of the pandemic. And they collected all data regarding the demographics, comorbidities, the labs, the hospital course. And the data was collected for a total of about 1,480 patients. And within this, about 567 received at least one type of organ support. And that's what you're seeing in this little chart here. So to walk you through this chart, the patients that are in red died, and the patients that are in blue survived to the hospital discharge. If you look at the picture, you'll see in the bottom the combination of therapies of organ support that the patient received. In the first column, for example, the patient mainly received vasopressors and invasive mechanical ventilation. In this group, almost half died and the other half survived. But more interestingly to me, if you look at the numerous other combinations of respiratory support that was used, you see that a lot of patients, not as many as intubation, were on high flow, and a lot of them survived. And there's a lot of people who are on a combination of high flow and IMV, and more of them survived as well. So how do you really assess the differences in outcomes in these patients when the therapy they receive is so varied? Like some patients got intubated, some patients got both, some patients got all three of them. So how can you really assess what the differences in outcome is when people are getting a very different combination of therapies? So then we'll focus in on this from this period in our own specific ED data. Again, so this was a multi-center retrospective observational data from our own system. So we collected all adult patients with severe COVID-19 infections who required an ICU admission from the 5 system EDs at the time. We had a total of 634 patients that were enrolled. Of them, these are the different types of respiratory support they required in the ED. So about 70% were on just low flow oxygen in the ED. 17% were on high flow and or NIV. About 8.5% got mechanical ventilation directly, and about 6.5% got a combination of high flow or NIV prior to mechanical ventilation. So when you take this data and you look at their outcomes, we found a couple of interesting things. One, we looked at patient level predictors of what was associated with a particular choice of therapy, not their outcomes, but just like what influenced the selection of a device. So accounting for clustering by site, we used a multivariable regression model to examine both patient and system level factors. We found that older age decreased the odds of being on mechanical ventilation compared to low flow oxygen. However, severity of illness and underlying lung disease increased the odds of being on mechanical ventilation. It also increased the odds of being on NIV or high flow before going on mechanical ventilation. So patient factors, if you're sicker or have lung disease, you're more likely to get mechanically ventilated or get non-invasive respiratory support. Not very surprising, but it was interesting that older people were also were at decreased odds of being put on mechanical ventilation, perhaps considering their ability to survive or not on IMV. But for me, the biggest factor, the most important takeaway from this data was when you looked at our own system factors and you looked at the workload, we found that as ED workload increased, the odds of patients being managed on high flow or NIV prior to being on mechanical ventilation increased almost 8 to 12 fold. So it doesn't matter controlling for all other things, patient factors, just the fact that the ED was busier significantly increased the odds of them going on non-invasive and high flow before they got mechanically ventilated. So we talked about patient factors, we talked about system factors that can affect the choice we make. But I'm also going to focus a little bit on provider factors. So I sent out a survey to our fellows, our pulmonary critical care fellows, with a list of 20 brief scenarios, which you see listed here. And I asked them if high flow nasal oxygen would be something they would choose in any of these scenarios. And as you can see, and you can see in the graph how many of them answered yes in the bar chart. The good news is that there's some agreement where they would or wouldn't use high flow nasal oxygen. The pink highlights scenarios where they would never use high flow nasal oxygen, and the blue highlights scenarios where they would always choose high flow nasal oxygen first. So they have agreement on about 6 indications, and everything else is very poorly agreed upon. Different fellows would pick or not pick high flow in these different situations. Similarly, we did the same survey for non-invasive ventilation, and there were no scenario where anyone agreed that they would almost definitely not use NIV, but there was some agreement on scenarios where they definitely would use NIV, and that's usually hypercapnic respiratory failure and or heart failure. So the point in me presenting all of this data is to kind of highlight that both with our initial case and all the data from our system that I've presented, is that the choice of respiratory support really varies by patient, system, and provider factors. And now that we have more and more non-invasive respiratory support available, we also see a lot more variation in practice than pre-COVID. And NIV and high flow failure requiring intubation and prolonged use of NIV prior to intubation may lead to worse outcomes. And these therapies are increasingly used in settings that they were not studied in. For example, a lot of the data that I'm going to present comes from ICU studies done by ICU physicians in patients that were admitted to the ICU, versus where we primarily now use NIV and high flow or outside of the ICU, at least within our own system. So the objective of the rest of the talk is that we'll review some physiology of lung injury in the spontaneously breathing critically ill patient. We'll review some evidence for high flow and NIV, and then we'll explore some risk scores and predictors of non-invasive respiratory support. So to get back to basics, the pressure necessary to inflate the lung is essentially comprises of the pressure that you need to overcome your airway resistance and inertance, and then the pressure to overcome the elastic properties of the lung itself. So when airflow is 0, for example, at the end of inspiration, the principal force maintaining the lung being open is the pressure in the alveoli minus the pressure in the pleura. And this is your transpulmonary pressure. So your lung volume and transpulmonary pressure are now inextricably linked. So now let's consider an anesthetized patient that's paralyzed on mechanical ventilation. You deliver some positive pressure, and the transpulmonary pressure is that positive pressure that you delivered, which is 9, minus the pleural pressure, which is 1 or negligible in the patient who's anesthetized and paralyzed. So the transpulmonary pressure is usually lower than your plateau pressure. And that tends to be, in this situation, 8 centimeters of water. But now think about someone who's on non-invasive, who's getting positive pressure, but also who's generating their own negative pleural pressure. In this situation, you're giving them 10 centimeters of water of pressure via their non-invasive device. And this is the typical 10/5 BiPAP setting that you're thinking of. And the patient themselves is now generating a negative pleural pressure of 15. So the transpulmonary pressure is significantly higher in this patient than you would see in a typically anesthetized patient who's not spontaneously breathing. So during strong spontaneous breathing, the two different pressures combine to inflate the lung, causing possibly worsening lung injury. Another idea of one of the pitfalls of spontaneous breathing is the idea of pendulift. So in a normal lung, you have negative pleural pressures that are generated by the diaphragmatic contraction, and that is usually transmitted equally and quickly and uniformly across the lung surfaces. And this increase in transpulmonary pressure during this normal breathing, the lungs exhibit what we call a fluid-like behavior, and the forces are distributed evenly across the lung. But think about an injured lung where you have some collapsed lung tissue. The collapsed lung tissue or the injured lung tissue exhibit a more solid-like behavior compared to the more liquid-like behavior of normal lung. So what happens here is when you have the same negative pleural pressure, this negative pleural pressure is concentrated more in the areas of injured lung, and it's unevenly distributed across the lung surface area. And the pressure not being evenly distributed and being more increased in the dependent atelectatic area of the lung is the concept of this heterogeneous ventilation pattern with increased pressures in the injured areas is the idea of pendulift, that it leads to localized barotrauma. So that kind of brings us to the big overall paradigm of the ventilation-induced lung injury or ventilator-induced lung injury. And you have your initial lung injury, which causes some capillary leak, which causes lung edema, which causes impaired gas exchange, leading to this increased respiratory drive, which also leads to increased tidal volumes and transpulmonary pressures, which kind of cycles this vicious cycle of lung injury. So something bad happens, which leads to this increased drive and increased tidal volumes and pleural pressures, leading to worsening lung injury and perpetuating the cycle. So you might think, okay, so why don't we just control everyone's breathing, make sure everyone's getting the same tidal volume and the same pressure, which is what we do. And shouldn't that mitigate some of this lung injury? And that leads us to this one study that helps you kind of understand that it's not just the volume that causes the problem or the pressure. So in this patient, you have this is a physiologic study that was done on a couple of patients with ARDS, and you see the CT scan that was done pre and post on inspiration and expiration. So this patient is breathing at a controlled ventilation at 6 cc's per kg, but with spontaneous breathing effort. And you see that the dependent area of the lung is now inflated during inspiration. So it doesn't actually matter that he was on controlled ventilation. Because of the spontaneous effort, you see that concept of pendulift and increased tidal recruitment of 15%. The same person on 16 kg, on 6 cc's per kg, but who's paralyzed, you don't see that tidal recruitment, or at least the tidal recruitment is attenuated. So again, why don't we just intubate everyone, paralyze them, and put them on like a controlled ventilation? Probably, because then we're gonna have a lot more trach patients than we would like. Again, what are some things that we can do to potentially reduce this? PEEP can help. So if you see the same patient, this is your airway pressure and below is your transpulmonary pressure. And you can see the wide swings. It's almost 10 centimeters of water of transpulmonary pressure. But you give them PEEP, the airway pressure remains the same, but then you have a reduction in your transpulmonary pressure. And this can be, this was nicely demonstrated in some PET scans that they did on patients, again, pre and post low PEEP. So this patient had low PEEP. This was the first PET that was done. And you see when you have lower PEEP, you have much more inflammation than when the patient has high PEEP. That inflammation is attenuated. So all that data kind of led me to say, oh my gosh, spontaneous breathing during lung injury is bad.
No.
It causes high transpulmonary pressures, high volumes, tidal recruitment, but maybe PEEP can help. But so that leads us to say, okay, maybe we should paralyze everyone. Should we paralyze everyone or not? And thankfully, we did a very expensive, very large study looking at neuromuscular blockade in patients with acute respiratory distress syndrome. This was the ROSE study, and it was supposed to replicate or address the mortality benefit of neuromuscular blockade that was reported in the Accurasis trial through the ARDSNet trials. But the ROSE study, which enrolled about
your computer has been locked up.
1,006
address was used
patients.
without your knowledge or consent to visit websites that contains identity theft virus. To unlock the computer, please call support immediately. Please do not attempt to shut down or restart your computer.
Okay. So the ROSE trial essentially showed that there was no mortality benefit between those that got paralyzed versus not. And that was different than what the Accurasis trial had shown. And part of the reason that people think that this happened is that in the ROSE trial, most of the patients who were deeply sedated versus those that received deep sedation and neuromuscular blockade, there wasn't a significant difference in their vent synchrony. For example, in the Accurasis trial, there was a lot of reverse triggering that led to increased volumes and increased pressure in patients who didn't get any sedation. But in the patients who are in the ROSE trial, a lot of them didn't have this reverse triggering or increased drive that was seen in the patients in the Accurasis trial. So the advantage of paralysis might be primarily in patients who have increased drive that is uncontrolled with deep sedation. So kind of going back to our lung injury paradigm, perhaps we should focus on these two factors as modifiable factors when we're choosing our respiratory support. If we can help reduce the respiratory drive and have some semblance of a control on the tidal volumes and plateau pressures they're receiving, perhaps it doesn't matter which type of respiratory support you choose, as long as you're able to mitigate either the drive or the tidal volumes and plateau pressure the patient's requiring. I'm just keeping an eye on my time. So I just wanted to present again some more data on like non-invasive use in patients with acute respiratory distress syndrome. This was a prospective observational international multi-center cohort study that enrolled about 218 patients across 2,800 patients across 200 hospitals across the world. And of them, about 15.5% were managed on NIV prior to intubation. And from this observational data, we saw that NIV failed in both mild, moderate, and severe ARDS patients, but it's more likely to fail in the more severe patients. NIV failure was independently associated with an increase in ICU mortality. And ICU mortality was higher in NIV patients that were eventually intubated versus those that were invasively ventilated directly, especially if their PF was less than 150 millimeters of mercury. So we can say that in this data, they show that NIV failure is worse, but why? So when you look at the predictors of intubation with patients with hypoxemic respiratory failure, who are treated with a non-invasive ventilation strategy, you find that if their respiratory rate is high, that increases their odds of failing. If their PF is low, that increases their odds of failing. And if their tidal volumes that they're getting on non-invasive ventilatory support, whether it's high flow or NIV, is greater than 9 milliliters per kg of ideal body weight, you also see an increase in failure, but it's also independently associated with a 90-day mortality. So all of these different aspects, the respiratory rate and the tidal volume, are all kind of pointing towards, obviously, a little bit more towards drive. What is happening with the patient that when you put them on these respiratory support strategies, that you're not able to reduce their respiratory rate, or they're taking high tidal volumes. So the predictors of failure and worse outcomes are both severity of illness and volume trauma. So those are kind of simple ways to understand how transpulmonary pressure and volume can affect your choice of support. But it's a little bit harder to understand how inspiratory drive, or patient's respiratory drive can affect their outcomes. And the only real data we have is from a mediation analysis that was done with all of the ARDSNet studies using driving pressure. And while this is mostly for intubated patients, we can extrapolate some of it towards our non-intubated patients as well. So we all know that driving pressure is essentially the ratio of the tidal volume to static respiratory compliance. And it's usually calculated at the bedside by subtracting the plateau pressure minus the PEEP. So in this mediation analysis, they used 3,500 patients from multiple separate ARDSNet studies, and they conducted 2 different analyses. Does driving pressure explain the mortality benefit that you see in the different strategies? And then they divided up all the patients in different combinations of PEEP, plateau pressure, driving pressure, and tidal volumes to see if there was any particular combination that was consistently associated with a mortality benefit. So in the ICU, if you have a patient that comes in, typically we always put everyone on a tidal volume controlled ventilation, especially if they have ARDS. But if you look here, you'll see that this is just it's odds for barotrauma, for example. As you increase your plateau pressure, your driving pressure, your odds adjusted for barotrauma increase. However, you can increase your tidal volume, and the odds don't necessarily increase in the same way. So in these patients that are listed here, you see as the driving pressure goes up, the odds of barotrauma goes up, but that's not necessarily consistent with tidal volumes. And this is a little bit more complicated, but I think it gives you a little bit more interesting data. So if you look at sample A, these are the number of patients that are in these different groups. The plateau pressure is going up, but the PEEP is the same. And the relative risk of death in these patients is going up as the plateau pressure goes up, or as the driving pressure is going up. So compared to that, if you have patients where the PEEP is going up, but the plateau pressure is going up, but the driving pressure remains the same, you don't see a difference in mortality at all. That relative risk stays flat. The PEEP increases, but the relative risk stays the same, even if the total plateau pressure is going up. But if you look in the last example, you see that the PEEP is going up, but the driving pressure is actually going down. And as long as the driving pressure is decreasing, you see a mortality benefit, as in the relative risk of death is actually decreasing. So that kind of, and then the similar thing is seen even when you look at across the board. If you look at tidal volumes more closely, the plateau pressure is the same across all patients. But if you look at tidal volume alone, no matter how low you decrease the tidal volume, up from 10 to down to 6, you don't see a relative difference in their mortality risk. However, if you decrease the driving pressure, you do see a significant decrease in the relative risk for death in these 3,000 patients. So essentially, the crux of the mediation analysis comes down to this. Even under protective ventilation strategies, that's when you are under 30 centimeters of water of plateau pressure or under tidal volumes of less than 7, you don't significantly see a difference in mortality benefit. However, when you look at the driving pressure, when you see a decrease in driving pressure or the drive to inflate the lungs, you do see a decrease in mortality benefit. So now going back to our paradigm, spontaneous breathing during lung injury is bad. I would say probably increased drive is probably the primary mediator for what's causing the lung injury. So we can say probably not spontaneous breathing, but if it's increased drive, that might be a problem. And going back to our original question, does our choice of respiratory support during a patient's clinical course matter?
Of course.
Perhaps not. If we're able to adequately support them and support their respiratory drive with our chosen level of support, then probably we don't have to intubate every patient that we approach. If we can put them on BiPAP or put them on high flow and reduce the drive and help put them on protective settings, then you probably don't need to intubate every patient you come across. So the driving pressure example sounds great, but how are you going to measure driving pressure in someone who's spontaneously breathing awake patient on high flow? There's not a lot of data out there for those patients. But there's this one interesting, elegant study that was conducted in Italy in 61 patients who came in with acute hypoxemic respiratory failure who were put on high flow. I don't know how they managed to do this, but they put in esophageal pressure probes on all of them, and they correlated that the change in pressure in the nostrils correlated very well with the change in esophageal pressures. So instead of doing an invasive measure, they looked at a non-invasive, easily obtainable nasal pressure measure. And they found that the change in esophageal pressure during spontaneous breathing, which is a surrogate for inspiratory effort or drive, correlated very well with the change in the change in the pressure of the nostrils. And then they followed that up with another study to look to see if this change in the pressure in the nostrils was also predictive of whether or not they had high flow failure. And it was. If you have a patient, they have a certain amount of nasal pressure, change in nasal pressure when they're breathing, you put them on high flow and that change is less, or you improved their inspiratory effort, they saw that it was more predictive of being successfully treated with high flow and not requiring an IV. So this is an area of like future research where we can do bedside assessments of patients' response to therapy quickly versus waiting a couple of hours for a blood gas or having the patient decompensate. So in a quick summary, we know acute hypoxemic respiratory failure is a common hospital presentation. High flow and an IV is very often a first step in management of these patients, but the incidence of failure can be high, and it's reported as high as 10 to 25%. And it's usually because either the patient was inappropriately selected, or the device was inappropriately titrated, or the patient is not tolerating the mask that they're on. So keeping that in mind, we'll quickly review the evidence for NIV high flow versus invasive mechanical ventilation. So there have been several studies that compared all of the different types of devices that are available for us to use non-invasively before we go down the route of intubating someone. That includes helmet bilevel, helmet CPAP. We don't have this at MSH, but they're common in Europe as well as in Canada. We have face mask CPAP and face mask bilevel, and then we have standard oxygen therapy. This is low flow oxygen or non-rebreather, and then we have high flow nasal oxygen. So in this study that essentially combined 36 randomized controlled trials, they conducted a network meta-analysis including over 7,000 patients, and they looked for a mortality analysis in only 30 of these trials. So the network diagram kind of tells you how many patients were in each arm. So the bigger the dot, the more the patients that got that therapy. The lines show you the trials that were conducted comparing one versus the other. So there were 9 trials comparing high flow to standard oxygen therapy and 11 trials comparing high flow standard oxygen therapy to face mask bilevel. So putting all the data together, they conducted a network meta-analysis to come up with this big chart. It might seem overwhelming at first, but it's interesting if you dig into it. The results presented here are the absolute risk difference per 1,000 patients with the 95% confidence intervals. All estimates are network estimates, so the negative values indicate fewer events and positive values indicate more events. And when you look at the overall colors, the different colors or the different grades of colors tells you whether the benefit was definite, probable, or maybe, and whether or not it was a positive or a negative effect. So if you look at overall, there were 300 deaths in the standard oxygen therapy per 1,000 patients, and that was reduced to 63 deaths, fewer deaths in those patients that were treated with high flow. But if you look, you can also look comparatively between the groups to see if one is better than another. But if you look at, for example, if you look at helmet CPAP, there were almost 231 fewer deaths than standard oxygen therapy. And you can compare between the two to see which one's better. So compared to helmet CPAP versus high flow, helmet CPAP is better. But compared to face mask bilevel, it's not. So, but you can also look across. High flow nasal oxygen reduces the risks of death, reduces the need for invasive mechanical ventilation, reduces hospital duration. It was equivocal for ICU duration, and it had more ventilator-free days than standard oxygen therapy. And similarly, when you but it wasn't as good as helmet CPAP or bilevel, but it was much better than face mask bilevel or CPAP. So overall, when you approach the patient with acute hypoxemic respiratory failure, I would probably first reach for high flow if in the absence of having helmet, CPAP, or bilevel. But again, kind of going back to what we talked about, if I put them on high flow and I don't see a significant benefit or reduction in their physiology or their improvement in their physiology, then I'll probably proceed with intubation before waiting a couple of hours or days before going down that route. And finally, I'll end with a brief note on exploring risk scores and predictors of non-invasive respiratory support and the need for IMV. We often go by kind of looking at the patient and saying, oh, the patient looks okay, let's just continue. But I've already presented some data on a physiologic parameter that you can use to potentially predict high flow failure, that is the change in nasal pressure. But there's also some scores that have been validated that have a lot of evidence that's being gathered that show that they can also be very predictive. So this is the original paper that was published by Roca in the Blue Journal, but really it's called the ROX index, which is the SpO2 over FiO2 over the respiratory rate. And it has a very strong body of literature supporting its predictive nature. So if you have a ROX index that's greater than 4.88 at 12 hours of high flow, then the probability of you being free of mechanical ventilation is pretty high. And this has been shown, it has a pretty good RSC, and this has been shown across several different types of respiratory failure, as well as COVID-related respiratory failure. So anyone who goes on high flow, who has a ROX index that's greater than 4.88, they tend to do fine. So that can be a little reassuring for us. But again, this is only predicting whether or not they're going to fail, but it doesn't tell us anything about what happens if we actually use it to intubate someone. So this is a study we did with our own data in the ED, and it's looking at a retrospective cohort. So what we did was we took patients in the ED that were started on high flow, and then we kind of divided them up. So there's a lot of patients that come in, and a lot of them do well and they're fine. It's really hard for us to say why did they do better than others. So we calculated the ROX index on all the patients that came in with high flow, that came in on high flow in the ED. And then we looked at what the ROX index predicted. The ROX index predicted high flow nasal cannula failure, and they got intubated like the ROX index predicted. They got ROX concordant care. But if the opposite happened, if the ROX index said, hey, intubate the patient, but they didn't get intubated, then they got ROX discordant care. So what we did was we compared patients who had ROX concordant care with ROX discordant care to see what their outcomes were. So we looked at a total of 335 patients. We had to exclude a few because they didn't have good data on high flow, on their high flow. And then 67 patients were DNR, DNI who couldn't get intubated, so we had to exclude them. So in a total of 233 patients who were on high flow in 2023 in our Mount Sinai ED, we had 191 patients who got ROX concordant care and 42 patients who got ROX discordant care. And when you look at their odds of persistent organ dysfunction of death, this is after adjusting for age, comorbidities, and weight. We found that those patients who had ROX discordant care had an increase, had a 9 times increase in odds of persistent organ dysfunction of death. And that was, again, primarily driven by mortality. So ROX discordant care led to significantly worse outcomes, at least within our system and our patient data. So that kind of led to my current work that I'm working on, which is this non-invasive respiratory support dashboard that we're working on that has all the patients who are on high flow within our hospital, and the ROX is automatically calculated and color-coded for the respiratory therapist to use and to help guide the primary team in managing the patients who are put on high flow. And with that, I'll leave you with a few considerations. A lot of the times we put patients on different types of support, but we need to consider that the monitoring is congruent to the level of support. And I didn't really I talked about the different types of devices we select, but I didn't talk about combination therapies. A lot of our patients just go back and forth, and there's very little data on combination therapies. We also don't know a lot about weaning. How do you come down on high flow? How do you take the patient off of these support devices? And we know a lot that there's physiologic and clinical parameters that we can use to assess a patient's response to therapy. It's not always that everyone requires high flow, NIV, or intubation, but it's really how they respond to these therapies that should drive our selection of these devices. And with that, I will stop.
Dr. Goel, thank you so much. That was such a wonderful overview and talk. There was a lot of discussion in the group chat about some of the thoughts. So I know Pranay and some other people were making some comments. So Pranay, do you have any comments that you'd like to start with for Neha?
Sure. I guess one of the things we did talk about at the very beginning was you were talking about the ROX index, and I actually wonder whether that's something that we could have done for the guy in the chart. And I know that's something that you are actually doing for us in the hospital writ large. One of the other things is that I think when we're talking about like the driving pressure, one of the things I do see that we do a lot is actually we put people on very low tidal volumes, but keep the respiratory rates at like 35 and up and like paralyze people to maintain very high respiratory rates. And I wonder if there's an inflection point at some point where actually that many cycles is self-injurious, right? One of the reasons why I think we focus on driving pressure is because it's easily measurable. It's in the EMR, it's tabular data. Whereas things like work of breathing is like an integral of pressure. It's not easy to calculate. And it's not actually captured in the EMR. I know anesthesiologists actually calculate this. They think about the risk of post-op respiratory failure, post-op reintubation actually increases with mechanical power regardless of how much actual like pressures they're giving. So I wonder maybe I was just like speculating, because as ventilators become more powerful computers, maybe one day we'll actually be able to actually do this ourselves as well.
So to that point, actually, I know I presented a lot of data on driving pressure. I only did that because that's a more easily available measure compared to mechanical power. The same mediation analysis was done using mechanical power as a predictor. Is that the primary predictor or driver of the outcomes that we saw? And that was actually more predictive of someone having a more successful outcome from their lung protective ventilation than even driving pressure. I think it's a combination of things. But if you look at the actual data, they're not mitigating the injury by decreasing the tidal volume. They're mitigating it by increasing the PEEP. So at least in the data that we see, at least it's flat when you increase the PEEP and the driving pressure stays the same. versus if you go down on the tidal volume, it doesn't necessarily improve the outcome. The mortality stays about the same. So in my mind, I only try to correct for driving pressure if I'm able to do it through PEEP. And I think, like you said, tidal volume is kind of like a false way to do it. Because you also increase your dead space ventilation by just increasing your respiratory rate and your dead space fraction.
Thank you. Is there other questions from anyone else in the group? Dr. Goodwani, looks like you.
No, I just wanted to thank Dr. Goel for such a wonderful review of, these conundrums that we face. And, it's obvious that there isn't any one answer, but this kind of guidance is very helpful. Thank you.
And for everyone to remember, the talks will be posted on our YouTube channel. That's at the end of all of our invitations for grand rounds. Please make sure you submit for CME credit for today. It's 3083 is the code. And if there's any other questions, I'm happy to open it. If not, we can have 5 minutes before we switch to our critical care meeting.
Thank you.
If not, okay. Thank you, everyone. Thank you, Neha.